Hi, everybody. Hope you're all well. So I've got a nice, interesting ECG for us to go through today. So this was sent to me by a local doctor, one of our GPs, and a patient who presented to him with chest pain, new onset. And, the patient was in quite a bit of distress, and he wasn't sure if the patient required more than what he could offer. In other words, whether to refer the patient or not. So this is quite an interesting ECG, and we're going to go through it, and we're going to look at particularly left bundle branch blocks, and we're going to look at Sgarbossa's criteria. I'm not going to try drag it out for too long. All right, so let's have a look at the axis first, which is lead 1 facing upwards and lead AVF also biphasic. So we can say it's within the realm of normal. What is interesting is once we get to the rhythm, we can see we've got normal P waves. We've got a normal PR interval. We've got a QRS following every P, but our QRSs are wide. And the reason for this is that we have a left bundle branch block going on in this patient. So this creates a rather interesting scenario. And the interesting scenario that we have is with the left bundle branch block, it often creates ST elevations, which we can see here in ST depressions. So is this an acute ischemia or not? And of course, the rhythm was quite regular. So it was technically a sinus rhythm with the bundle branch block, and we had 1, 2, 3, 4, about 75 beats per minute. So that was reasonable. Now, if we go through all of the zones, so the inferior zone 2, 3, AVF, we note that we've got this evidence of this left bundle branch block, more noticeable, of course, over V5, V6, leads 1 and AVL, where you would expect to see it to a greater extent. So the reason why he was worried initially was that he actually saw what he thought were Q waves. And actually, after we had a look at it, then we realized, no, this is you can see a little R wave over there. So this is actually an RS complex. It's not a Q wave. This, you could argue, is probably a Q wave, but there, if you look there, you can see there's a little R wave that precedes the S wave. So it's actually an RS complex. So the question that we had to ask ourselves is, number one, how severely ill is the patient? And number two, does it fall into Sgarbossa's criteria? So if you guys had watched the previous one where we discussed left bundle branch blocks and Sgarbossa's criteria, remember that we have something called concordancy and discordancy. So concordancy, for example, let me try and draw this out. I'm going to do the best that I can. No, you guys know my skills are not that good. So let's draw out one here. So let's say we've got a QRS complex that looks like that. And then you have your ST segment going like that, all right? So this is concordancy. So that means your QRS and your ST are basically in concordance with one another. So for example, both of these are showing a positive deflection. And discordancy is where, for example, you get, let's say, with this wide QRS complex, and then, sorry about that, and then you get an ST, for example, that looks like that. So you've got a QRS complex going in one direction, in this case, a negative deflection, and an ST that's going in a positive. So that's discordancy. So discordancy is extremely common in left bundle branch blocks, and we can see it here as well. So these are discordant changes. Now, if they are concordant changes, you're only looking at very small deflections. So if you have a concordant change, so let's say, for example, this QRS was going up like that, and on both of these, and you had maybe 2 blocks going up, that would really signify that you had an acute ischemic event that's going on. And once it's discordant, you're looking for more than 5 blocks, which we don't have here. We only got about 2 or 3. However, the one thing that made us worry was this patient had symptoms of an acute ischemia. So I'm going to just try and put it in here. So what we had was, I think if I remember correctly, it was a 65-year-old female. All right. With a history of hypertensive heart disease, no previous ischemic heart disease, all right? So no previous ischemic heart disease. And the patient was diaphoretic, was diaphoretic. Pain, not typical. So she was having pain in the central chest, but radiating to the right shoulder. And I actually get worried when it is going to the right shoulder, because it's actually shown a higher higher proportion of patients with central chest pain going to the right shoulder, especially amongst our female patients. They tend to present more atypically. So, these were the things that she had. And, that was basically what she was presenting with. And she did respond to nitrates that the doctor had given her in the rooms at the time. So she did show a mild response to that. So there were two possibilities over here. And the first possibility, of course, was that this was just an anginal attack, and she had had previous ischemic heart disease that was not picked up. Or number two, this was an acute ischemic event that was presenting as a new left bundle branch block. So given what we saw on the patient and given how she was presenting, my advice to the doctor was that we should treat the patient as an acute coronary syndrome. So this patient was then transferred. She went to the private medical facility in our area. The cardiac enzymes did not show much of a change, but there were some worrying upward trends apparently over the next day or two. And because we didn't have previous ECGs, we had to assume it was a new left bundle branch block. In the end, she was diagnosed with unstable angina. And the left bundle branch block cause was not really figured out. She was still going to visit a cardiologist to try and see if there had been previous ischemia. They were going to do electrophysiological studies for her to see what was going on. But in the emergency department, of course, you don't have access to all of this. So in the emergency department, we look for concordance, which tells you on, and I must be honest, when I've seen concordant ST elevation, so in other words, your QRS goes up and your ST is elevated, or your QRS is down, but your ST is also down, 99.9% of the time there is an ischemia going on over there. And it will tend to follow in the areas where you'd expect it to be. And if your patient has discordancy, it's quite a common finding. However, severe discordancy is more in keeping with an acute ischemic attack. If you don't have a history of ECGs or something to show you that there's a previous left bundle branch block, if you see a new left bundle branch block, treat it as an acute event. Now, the only thing that we missed out on was we didn't get a follow-up ECG because this was done at the emergency department, but we would look for dynamic ST changes. We would look for the presence now of Q waves of a worsening bundle branch block, possible bradycardia. These are the things that we would look at. So in your emergency department, if the patient comes in like this, you should be repeating your ECGs every 10 to 15 minutes. Now, the reason for that is twofold. Number one, it tells you about these dynamic changes. And once you have dynamic changes, it leads you to the point of thinking this could well be an acute event. And the second thing is that depending on the time of onset of pain, you may get negative cardiac enzymes. So remember, cardiac enzymes only start to appear 6 hours post-pain. So if you take it very quickly, you're not going to see that. This brings me back to, well, I suppose you could call him a patient, but he's actually my cousin. There was also a doctor, a GP working in KwaZulu-Natal, who had severe chest pain, severe chest pain in the middle of the night. His wife took him through to the emergency department. The emergency department did everything. They found also a left bundle branch block, but his enzymes were fine at that time. And he had rushed through because he had all the symptoms and a strong family history. In fact, his dad, my uncle, has had more bypasses than I can count. In fact, we often joke with my uncle that whenever he's sick, he just goes to ICU and they give him a high five in his usual bed because he's been in there so often with anginal attacks and acute ischemia, they did it. He then phoned me and he told me, listen, this is what we're experiencing. And he was still not sounding good and he was still experiencing pain. The nitrates were not. And I told him, go back now, redo your enzymes. It's been now about 6 hours. And they found his TROP-Ts and his CKs in the thousands. And he was admitted, went into ICU, had stenting and a bypass because one of the vessels was so badly occluded. Unfortunately, he continues to smoke, so that doesn't help him as but in any case. So it just shows you how we approach these patients. Anyway, I hope you guys enjoyed that. Lovely little ECG that just gives us a good insight into what we can see in real life when we are in our practices, be it private, in an emergency department. These are the things that you can face. Well, one more thing is, what should you do for this patient? So it depends on where you are. If you're in an emergency department, your acute coronary, your ACS protocol comes into play. If you are in a private setting, maybe a private doctor's office, not affiliated with the hospital or whatever it may be, you would give the patient discipline. You would give the patient possibly nitrates as well. But of course, remember, not for an inferior infarct. And you would, if you have statins available, can often give the patient statins, although some people have suggested that could lead to further rupture. Apologies for that. I was receiving a call and at the same time unable to take the call and pause. Anyway, yeah, so that just tells you about what you can and can't do. And yeah, so hopefully this will help you in the future with patients who present to you with new left bundle branch blocks, suspected new left bundle branch blocks. All right, keep well. Bye.